Hello, I'm Dr. Ken Landau. We're going to be continuing our discussion of irritable bowel syndrome. Irritable bowel syndrome, we know, is phenomenally common, affects somewhere around 10-15% of the entire population. We know it's associated with recurrent abdominal pain, oftentimes associated with either diarrhea or constipation, a change in the form or frequency or appearance of the bowel movements. We know that if we look overall, we find that this condition is often misdiagnosed, underdiagnosed, or unfortunately, a lot of people are subjected to lots of different tests. They get the upper endoscopies, the lower endoscopies, the colonoscopies. They spend an awful lot of time, awful lot of money, when indeed careful history and physical examination is basically all that's required to make the diagnosis. Why do people get the irritable bowel syndrome? We just don't know. There are a lot of different concepts. Concepts might have to do with the bacteria present in the gut. Maybe it has to do with some hypersensitivity of the gut. Maybe some abnormality as far as the nerves or the chemicals produced. Maybe serotonin, acetylcholine. Maybe it has to do with a little minor inflammation that nobody has really been able to get a good handle on. Maybe it has to do with a genetic sensitivity, a genetic proclivity. We know it seems to aggregate in families, and certainly if you have an identical twin who has the condition, then you're more likely to get it. We know that there's a major confusion as to whether it's the environment that you grow up in or whether it's your genes. Maybe it's just a single genetic abnormality. One gene might do something. So for instance, the gene that seals off the intestine, that gives the intestine the tight junctions, might be abnormal, and then you might leak some kind of a chemical into the body. Maybe that's going to be the cause of this condition. Probably not, but that's what some people think. So now we have a condition that affects tens of millions of individuals, seems to get better over a period of time in many people, seems to be one in need of some kind of therapy. And the question is, what kind of therapy? We have all sorts of therapies that are available, both pharmacologic and non-pharmacologic. Certainly, for a condition that's not associated with any increase in cancer, increase in death, increase in disability, except through, unfortunately, some testing, we have to be careful to have an appropriate approach to the condition. We have to remember it's benign, it's chronic. We have to educate people. That's the principal job in the irritable bowel syndrome. Educate people as far as the nature of the condition and the non-malignant, non-lethal, just unfortunately irritating nature of this condition. And we also have to realize that there's a major placebo response. So before you go and take medicine, before you take anything that might hurt you, and there are a lot of medicines on the market for this condition that have significant number of side effects, what you have to do is you have to realize that the placebo response in this condition, the placebo response, is around 40%. 40% of the time, people given pills that have absolutely no activity going to improve their symptoms, and it ranges anywhere between maybe a low of 30% to as many as 80% of the people who get therapy for this condition may well do well, even though the therapy has absolutely no active ingredient. And that's even when the people know that they're taking a placebo. So you have to realize that we have an awful lot of medicines. We have a significant number of medicines. But what we want to do is we have to realize that, number one, our goal is to reduce or hopefully even eliminate some of the symptoms. There are many different kinds of symptoms. Remember we said that associated with irritable bowel syndrome, a significant number of people have fibromyalgia, a significant number have chronic fatigue syndrome, temporomandibular joint problems. A lot of people have symptoms of anxiety or depression. All of those have to be addressed. That's beyond what we're going to talk about today. But we have to realize that people who have irritable bowel syndrome, we have to, one, take care of the pain and discomfort. That's one major problem. Another problem is we have to take care of the either constipation and or the diarrhea. And of course, what we use to treat people for diarrhea is not going to be the same kind of medicine as we treat for constipation. So we have to use a variety of drugs when drugs are appropriate. Might be as simple as convincing people that they have to have a certain time to go to the bathroom. So if you have constipation, one of the things we like to do is train your bowels. Maybe we like to train your bowel and have a certain set time to go to the bathroom. Maybe we like to stimulate the bowel a little bit with some coffee or some prunes or something of that nature. And certainly when it comes to stress, obviously stress reduction is very important. And stress reduction can come in the form of medical therapy, emotional therapy, realizing what the problem is. Certain kind of drugs seem to precipitate the problem, so we stay away from those kind of drugs. And diet. Certain foods in your diet are going to make matters worse, so obviously you have to stay away from that. One of the simplest treatments for any kind of medical disease, doesn't matter whether we're talking about this one or another, is physical activity. The more people seem to exercise, within reason, the better off they seem to get. It changes the nervous system, changes the way we deal with pain, discomfort, distraction, and all of the rest. So you can go out and you can swim, run, jog, bicycle, hike, or for some people, yoga might be all you need. Now, some people, because we're talking about gastrointestinal disorders, believe that fiber is the appropriate treatment. Fiber certainly is one of those shibboleths nowadays. It's one of those popular items to consider. And fiber might have a role, might be helpful. We just have to make sure that we get the right kind of fiber, because remember, not all fiber is alike. And as a matter of fact, in this kind of a condition where bloating is frequent, where abdominal distension and distress and discomfort is one of the mainstays of the disease, you have to realize that if you consume fiber, you may well get increased bloating, increased discomfort. It seems that we have to consider maybe the fiber we get from fruit, the fiber we get from nuts, probably pretty good. We have two different kinds of fiber. We have the soluble fiber and we have the insoluble fiber. Most people think about fiber and they imagine the bran and the wheat. That's insoluble fiber. And actually, in the irritable bowel syndrome, especially the constipation part, better source of fiber is what we call the soluble fiber. How much fiber should a person get? Well, anywhere between maybe a supplement as low as 5 grams to 30 grams, certainly somewhere between 20 and 30, 35 grams of fiber a day would be appropriate for many people. And if you get enough fiber, you can probably decrease the constipation and you can probably improve some of the global symptoms, but you don't seem to get rid of the pain. Now, when we talk about soluble fiber, we're talking about things like metamucil, psyllium, and aspagula. You can go get those, are the outer husks, and it's from the plant called plantago. Seems to be relatively helpful. If we look at people who supplement their diets with 10 grams of the soluble fiber, we're going to have a decrease in the symptoms of somewhere between 50 and 60%. That's significant. If you have the insoluble fiber, however, bran, wheat, you're probably going to only reduce your symptoms by maybe about 30%. On the other hand, remember I said placebo? Well, if you look at the placebo response, it's going to be about 40%. So the difference between the bran fiber, the insoluble fiber, and placebo is negligible. And if you consume enough of the insoluble fiber, remember that's going to ferment in your gut and you're probably going to have symptoms, and symptoms occur in probably 40% of the people. So you have to be very careful what kind of fiber you're going to take. One of the fibers, or a couple of the fibers, that have less ability to ferment in the intestine might be the calcium polycarbophyll or maybe even the methylcellulose. So those would be things that we could recommend. Now, when it comes to fiber supplements, there's certain that we don't. So for instance, people who take some lactulose. Well, lactulose can add to the bloating and the gas production. By that token, you want to avoid beans and sometimes carbonated beverages. And a lot of people suffer from what we call aerophagia. They swallow air, especially if they suck on straws and they consume their beverages that way. Well, you have to realize that foods don't cure the condition, but could make you theoretically feel much better. So the simple foods that you might want to try to avoid are the wheat and the dairy and the eggs and the coffee and maybe some yogurt and potatoes. Things that are in that family seem to make matters worse for some people, and certainly if a person is lactose intolerant, then consuming milk or dairy products might lead to bloating, so obviously get rid of that. And certainly fatty foods might further compound problem, because what fatty foods do is they delay intestinal transport, they can increase the hypersensitivity of the gut, and they alter the motor activity of the gut. So fatty foods don't seem to be very good. Now, what about gluten? Everyone's worried about gluten. And we'll talk about an offshoot of that in a moment, but suffice it to say that if we look at irritable bowel syndrome, 5% of the people suffer from celiac disease, 1% in the general population. So you have about a 5-fold greater risk of suffering from celiac disease with irritable bowel syndrome. So you might want to consider, but for the overwhelming majority of people with irritable bowel syndrome, a diet specifically devoid of the gluten, that's protein in the wheat, not going to be quite helpful. Well, again, there are certain kind of foods that seem to make matters worse, so you just go and you avoid them. A lot of people are now finding that if you switch to a low-carbohydrate diet may well significantly improve the symptoms and may improve the symptoms in 3/4 of the people. Now, if you happen to suffer from the constipation type of irritable bowel syndrome, maybe changing your diet, changing the fiber, maybe getting enough fluid in your body, maybe that's going to improve symptoms overall. So what do we know? We know that a lot of people suffer from bloating. Bloating is a difficult symptom to get rid of. We know that if you suffer from bloating, maybe we like to give you some activated charcoal or some simethicone to maybe absorb some of the gas. That might be appropriate. Certainly is inexpensive, certainly not associated with a variety of side effects. Laxatives might help some people, and that would be quite satisfactory. But the improvement with laxatives might be very short-lived, might not be as good or as great as most people think. We have an osmotic laxative, polyethylene glycol, PEG. You can go over, get that at the grocery store. That seems to work. That seems to improve the bowel function, increase the number of bowel movements. Maybe it decreases the gaseousness too, so that's kind of good. Another kind of medicine that people have toyed with is lactulose, but as we mentioned before, that probably isn't a good idea. Laxatives, kind of short-term, lots of different kinds. You can take the osmotic laxative, you can take a stool softener, bisacodyl, lots of things. But the most interesting and the most probably relevant concept in irritable bowel syndrome comes out of Australia. Doctors Peter Gibson and Susan Shepherd came out with the idea that for a variety of these functional gastrointestinal disorders, where there was some distension in the small intestine and maybe in the first part of the large intestine, maybe the reason that people were suffering from the distension had to do with the kind of foods that got into those areas, foods that hadn't been digested well in the upper portion of the gut and now were fermented by those bacteria that we talked about, fermented in the lower part of the intestine, and in the fermentation process, maybe they're releasing a lot of hydrogen, not methane. And maybe that has something to do with it. So they created the concept of the food map. And the food map stands for F is for fermentable, O is for oligosaccharide, D is for disaccharide, M is for monosaccharide, and polyol. Polyol are the sugar alcohols. And maybe these food maps, these kind of foods that are included in there, those carbohydrate-containing foods, poorly absorbed by the small intestine in many people, get into the large intestine, the lower part of the small intestine as well, and cause some kind of symptoms. Well, you have to realize that not all carbohydrates are bad. But osmotically, when the carbohydrates are where they're not supposed to be, when they're not broken down, when they're not digested, they're going to pull water into the intestinal tract. And when they pull water into the intestinal tract, and when they make gas, then a person may well develop some kind of symptoms. And the symptoms would be gas and bloating and cramping and diarrhea. So maybe for some people, consideration of a low food map diet is very appropriate. And as a matter of fact, maybe 70%, 3/4 of the people seem to control their symptoms when they consume a diet in the low food map category. I'll tell you what the low food map foods are in a moment. But compared to placebo may be about 20%, 25% of the people seem to get well on a regular diet. If we cut down on these food map foods, a low food map diet, 3/4 of them seem to get better. Doesn't change necessarily the stool consistency, but it certainly does change the stool frequency. So if we look at the food maps, well, a lot of fruits and honey and the high fructose corn syrup would be bad, dairy would be bad, wheat, garlic, and onion would be bad, lentils and beans would probably be bad. A lot of diet foods contain sorbitol and mannitol. Those would definitely be bad, and so too would the stone fruits. Stone fruits are defined as fruit with pits. So for instance, the avocado, cherries, peaches, and plums would be bad. So what could you eat? What would be appropriate if you had irritable bowel syndrome, and if you had significant abdominal cramps, and if on top of that you had an abnormal stool frequency? Well, it might be appropriate to have a low food map diet. So what you would like is you would like to have beef and chicken and eggs and pork and fish. That seems to make sense. You'd like to stay away from lactose, so you would like to have cream cheese or some of the hard cheeses, for instance, cheddar cheese or Swiss cheese would be okay. Soft cheeses, maybe like brie or feta or mozzarella would also be okay. Sherbet would be okay, and so too would yogurt. You would like an alternative to milk because milk has the lactose, so you might have almond milk, you might have rice milk. You could have tofu, you could have some walnuts and peanuts and pecans. You'd like to stay away from gluten. So when you're staying away from gluten, you stay away from the wheat and instead have oats, and maybe you have potato and quinoa and maybe even rice, and you can make that into the bread and the bagel and the pasta and the noodles and the pancakes, and that would probably be okay. And for fruit, we said don't have the stone fruit, but you could have bananas and blueberries and grapes and oranges and strawberries. And for vegetables, certainly potatoes and spinach and tomatoes and zucchini and carrots and cucumbers would all be very good. Now you should stay away from high food map foods. So high food map foods seem to cause more symptoms in irritable bowel syndrome. So that's the wheat, the barley, and the rye. Stay away from that. And then lactose. So the ice cream and the milk and the soft cheeses like cottage cheese and ricotta cheese, stay away from that. Sour cream. And you could have cashews and pistachios on this particular diet would be verboten, so you shouldn't have that. And certainly when we talk about those legumes that have a lot of fiber, you want to stay away from beans and just the miso and the soybeans and the soy milk, probably not good. And as far as fruit that would not be good to consume, well, you don't want the canned fruit, you don't want the apricots, you don't want the dates or the peaches or the mangoes, all bad. Plums and prunes, similarly bad. Stay away from cauliflower, obviously something that causes in the cruciferous vegetable family a lot of gas. And mushroom we want to stay away from. And foods that are made with the high fructose corn syrup. Well, that can significantly improve your lot. And certainly if you suffer from irritable bowel syndrome, I'd give it a shot because that seems to be the simplest, safest, least expensive, and least likely to cause side effects. Well, we know that stress is a significant problem in irritable bowel syndrome. And people who have stress, people who undergo stressful events in the course of their life, are going to have more symptoms. And sometimes these symptoms alternate between diarrhea and constipation. And we know that appropriate therapy, well, it doesn't have to necessarily be medical therapy. Could be some cognitive therapy, could be acupuncture, could be herb therapy, Could be a variety of relaxation or stress management or mediation or meditation kind of therapies, and they seem to be somewhat helpful, but unfortunately many of them require a therapist, and then they can get somewhat expensive. There's the concept that the bacteria in the gut need to be altered, and we have the good bacteria and the bad bacteria, and it seems like in the case of irritable bowel syndrome, maybe the bad bacteria are winning, but it's possible with something known as a prebiotic, not a probiotic, a prebiotic, a foodstuff that you might be able to consume that might increase the good bacteria. Sort of acts like mother's milk. Sort of seems to be one of those kind of products. Maybe we're talking about something like the trans-galacto-oligosaccharides that are acted upon by the good bacteria, and the good bacteria, the bifidobacteria, are increased in number. So that would be good, perhaps. Another concept with irritable bowel syndrome is something about the probiotics. Probiotics kind of difficult to talk about because they mean different things to different people. We have variable doses, variable strains, variable species, variable doses. But when taken appropriately, they might be able to decrease the inflammation, decrease the flatulence, and decrease the gut hypersensitivity, improve the global symptoms. Certainly is possible. How does it do it? We just don't know. We think it encourages the good bacteria, increases the good bacteria in your gut. Question is, what kind of bacteria? Well, first of all, we don't even know that when you go and buy the supplements that contain these probiotics, that they have anything in them. You might remember a recent story in the news that Target, Walmart, GNC had chemicals that they were selling as herbs that didn't have any of those herbs in them. So do we know that the probiotics actually have significant probiotics, that the bacteria are actually alive? No, actually, we don't know any of that. What kind of bacteria would you like? Well, the bifidobacterium seemed to be good. Saccharomyces seemed to be relatively good, probably others as well. When it comes to drug therapy, a lot of drugs being used for irritable bowel syndrome. The question is, do the drugs really work, and are the drugs really safe? Some are, some aren't. We know that this is a chronic condition, so if you take the drugs and you don't seem to be getting better in the course of a month or 2 or even 3 at the outset, then stop the drug. Shouldn't be taking them. Shouldn't be taking them on a chronic basis for a condition that might last for years or decades if the drugs don't seem to work. And unfortunately, because of inertia, we find that once a drug is prescribed, it often is refilled again and again and again. Well, one of the common drugs that you can get without a prescription is just Loperamide. Loperamide, for those people who have diarrhea, probably is pretty good. Seems to work relatively well. Changes the gastrointestinal musculature, allows you to absorb more water. Seems to be relatively innocuous for many people. We have another product you can get without a prescription, and that's peppermint oil. Peppermint oil is used more in Europe than it is in the United States. It seems to relax the smooth muscle. It decreases the pain and the discomfort and the distension associated with irritable bowel syndrome. And interestingly, even after you stop it, it seems to be associated in some people with persistent benefit. Well, how much do you need to take? It's tough to say. Most people would say somewhere around 200 milligrams, give or take, maybe about 3 times a day. But unfortunately, since it relaxes smooth muscle, it also relaxes the sphincter that separates the esophagus, the tube that goes down to the stomach, from the stomach itself. And when it does that, it might increase the likelihood of your suffering from some indigestion. We have other kind of antispasmodics. These antispasmodics work with that acetylcholine that we talked about a little while ago, that has to do with the nerve function. So these kind of medicines can be taken by mouth. They can be taken when needed, or they can be taken on a regular basis. Unfortunately, anything that affects acetylcholine can cause some kind of symptoms. Those are the same kind of symptoms that you would get if you were taking a drug. Maybe you have urinary incontinence if you're a lady. Maybe you're just taking a Benadryl. same kind of symptoms. So they cause dry mouth and dizziness and sometimes blurred vision. Sometimes you get constipation or urinary retention. But it does seem that these drugs can be helpful for a significant number of people. They're cheap, they're readily available. Drugs like Levsin or Bentyl, very commonly used. Another set of very commonly used drugs are antidepressants. We have two different kinds of antidepressants that are commonly used in people who have irritable bowel syndrome. And because irritable bowel syndrome is not thought to be a problem with depression, we can use a very low dose. And it seems like a low dose of these drugs seems quite helpful in many people. More so, at least if we're talking about the standard kind of antidepressants, the tricyclic antidepressants, they seem to work better for people who have the diarrhea-associated irritable bowel. These are drugs like nortriptyline, amitriptyline, dizipramine, imipramine, all of those at a low dose, maybe half or a quarter of the standard dose used for depression. And seems that they can very frequently help the pain. Not only do they help the diarrhea, but they can also help the pain. They slow the intestinal transport. So therefore, it would be better for people with diarrhea than with people with constipation. And if we look at the people who have, after they take the drug, probably about 50% of them still have pain if they take an antidepressant. On the other hand, about 75% of the people still have pain if they take a placebo. Now, we also have other kinds of drugs. We have the selective serotonin reuptake inhibitors, the drugs like Zoloft and Paxil and Prozac. Those drugs, and another drug in the selective serotonin norepinephrine reuptake inhibitor, that's Cymbalta. Those drugs seem to work well for the people who have the chronic pain. They seem to work in low dose. And they seem to work a little better, perhaps, in people with constipation-prone disorder rather than the diarrhea-prone. And then we have other drugs that work on the bile acids that are not associated with the antidepressants. We have, for instance, cholestyramine. That's a drug that was used once upon a time to help reduce your cholesterol, one of the original drugs. And this drug seems effective if a person has too much bile acid, and the bile acids are getting into the gut and causing some irritation. And then we have a condition where, as we mentioned before, there are some people who, for one reason or another, seem to have bacteria growing where bacteria don't normally grow very well. And they grow in the small intestine. So we have small intestinal bacterial overgrowth that can lead to a significant amount of bloating and pain and gas production. And it was thought that, well, maybe these people would do better if they were treated with some antibiotics. Maybe the antibiotics would kill those bacteria growing where they're not supposed to grow. Well, they came up with this idea that you could take a drug known as rifamycin, and if you take the rifamycin and you do it for 2 weeks, take 3 pills a day for 2 weeks, that you would significantly benefit because you would kill the bad bugs, the bugs growing where they're not supposed to. And indeed, at 4 weeks, there seems to be some benefit, and it continues on to about 12 weeks. By about 9 months after you take the course of therapy, seems like in many cases the symptoms have come back. The drug is relatively safe to take. We don't know whether it's working the way we think it does, whether it works on those bugs that are growing in the small intestine, or whether it just gets into the large intestine and affects the bugs in the large intestine. We do know it's phenomenally expensive. It costs over $1,000 for a 2-week course of the antibiotics. That doesn't make any sense. Well, if we're talking specifically about irritable bowel syndrome associated with constipation, what can we do? Well, diet and lifestyle change, obviously, that goes without saying. For some people, it might be something as simple as the polyethylene glycol type laxatives, the stool softeners, the medicines that help. We know that there are a lot of receptors for serotonin that are present throughout the gut. And depending on which particular receptor we have, and depending on the amount of serotonin in the gut, we know that too little of the serotonin may be associated with constipation. Too much of the serotonin may be associated with diarrhea. Maybe all that has something to do with it. Well, we have some pills some pills that are available, relatively newly available, for treatment of irritable bowel syndrome. With constipation, we have something called Amitesia. Amitesia is a prosecretory kind of medicine. What it does is it pushes some chloride out into the lumen, into the large intestine, and when it does that, into the intestine, when it does that, then it seems to take with it some water, some sodium, seems to make the stool softer, makes the transit time less, seems to speed up things, doesn't change the visceral hypersensitivity, unfortunately, but does improve the consistency of the stool, improves the straining. Person's more satisfied with their bowels. This drug was approved in 2006 for people who had functional constipation, and in 2008 it was approved for people who had the irritable bowel syndrome with constipation at a lower dose. It was based on just very small study. That study lasted for just about 12 weeks. You need about 12 people to treat in order to get one of them to get better. It's very expensive. You have to spend, without insurance, about $400 a month on this drug. And if we look at the likelihood of improvement with Amitesia, it's about 18% of the people get better when they take the drug, 10% of the people get better when they take placebo. It doesn't seem to be all that good. We have Linzess, another kind of drug in the same sort of family, does the same sort of thing ultimately, changes the fluid and electrolytes, pushes more liquid into the gut, and as a result, it's going to be associated with greater number of bowel movements, less pain when a person has bowel movements, increased frequency. Again, this is a relatively recent drug, just approved in 2012. It's expensive, costs about $300 a month to take the drug. If we look at the likelihood of improvement, well, maybe about a third of the people who take the drug seem to get better versus 21% of the people who take placebo. That's not so great. Maybe associated with decrease in the visceral sensation. But you have to realize that these drugs all have potential problems. They're only for people who have very severe disease, and unfortunately probably used for people who don't have very severe disease. But these drugs can have significant side effects, and it's cautioned that you should, number one, be a woman, and number two, have very severe condition in order to take these kind of medicines. We know that two other drugs in the same kind of family overall were taken off the market. One was known as Cisapride, and Cisapride, still around a little bit, but unfortunately this drug that was used for the constipation associated with irritable bowel syndrome caused some cardiac arrhythmias, taken off the market for that reason. Tegaserode, another kind of relatively similar medicine, both of these work on the serotonin. Well, that didn't have any arrhythmias associated with it, but unfortunately, it still had significant cardiovascular disease associated with it, and people had ischemic events, heart attacks. It was approved in 2002 and off the market by 2007, and in Canada, there's another medicine in Europe, the same medicine's available, called Resilor, and Resilor is highly selective, works in a fair number of people. It was approved in 2009 in Europe, in 2011 in Canada, but not yet in the United States, maybe not in the United States forever. It works sort of like the Amitesia and the Linzess. Seems to get the water and the sodium out in the gut. Seems that about a third of the people taking this drug seem to do well versus about 10% of the people on placebo. And again, it seems like we have fair number of side effects on these kind of drugs, so one doesn't want to rush into any kind of therapy. On the other hand, we have cholestyramine if you have the diarrhea and if you have bile acid malabsorption. Maybe cholestyramine is okay, or the simple laxative, maybe that's okay. We have Lotranex if you have diarrhea. Lotranex, and I can't understand how the price of these medicines gets so out of control. Here we have a drug that was originally approved, then it was withdrawn by the Food and Drug Administration. Now it's back on the market. And it's only, again, for women who have very resistant symptoms. And it's helpful in a small percentage of the people. But unfortunately, the cost of the drug is about $3,500 a month for not guaranteed results. So if you have irritable bowel syndrome, hopefully a change in diet is what's going to improve your lot significantly, and attention to the food map diet from Australia. And if you're interested in the food map diet, just type in FODMAP diet in the computer. Type it on Google or whatever search engine you use, and you'll come up with recommendations. And they seem to make sense, seem not to have associated side effects. You have to watch your diet, so do be careful. If you're careful about your diet, if you're careful about the stress, if you get your exercise, maybe that's the key to success. And interestingly, some people are now experimenting with melatonin. And some people believe melatonin, the simple over-the-counter medication that you get, it's a pineal gland substance produced in the brain, but also, interestingly, just like the serotonin, comes from the gut too. And it seems that in some people, it may well significantly improve gut function, works on GI motility, works as an anti-inflammatory drug, works to cut down on the amount of hypersensitivity in the gut. Seems beneficial, at least for some. Unfortunately, with irritable bowel syndrome, we have a condition affecting millions of people, a condition that has absolutely no test to make the diagnosis. We have a lot of medicines that are being pushed that probably are more toxic than they're worth, and we have a lot of old medicines that are not being used simply because people, I'm not going to take an antidepressant, I don't have depression. Well, maybe antidepressants work on a heck of a lot more structures than just simply those that cause depression. So with that in mind, I hope you've learned something about irritable bowel syndrome. Back again soon. Thank you for listening. I'm Dr. Ken Langdon.